So, health economists are actually pretty good at not offering any solutions. So I don't know how much of those solutions I'm going to be able to offer. But I gotta say, first of all, thank you to the committee for inviting me. I was really excited when I received the email, and I replied right away, and I said yes, exclamation mark, exclamation mark, exclamation. So that's 3 exclamation marks. I was really excited. And then I probably walked around bragging that I was going back to Oxford. I love the place. It's beautiful. And then I went back to read the email, and I saw that incorporated into that email was could you speak from the Canadian perspective? And then my heart kind of sank because it's a bit of a challenge. And it's a challenge for this reason, that Canada, while only 37 million people, is geographically very large. So we have 10 provinces and 3 territories, meaning that we have 13 different healthcare systems with different abilities to pay for health care. And so speaking to any one system or to all systems tends to be actually pretty difficult, especially if we're talking about resource allocation with different willingness to pay, and if we're talking about different decision-making processes at the jurisdictional level. So I have 2 disclaimers in this presentation. The first one is that this is not a comprehensive review, and I already have too many slides. So James Buchanan, could you keep an eye on the time and let me know if I'm talking too long, which I sometimes do. But the general outline is going to be fairly broad with some specifics around what I think methods are important in this context. So we're going to talk about priority setting generally in Canada, which is the means by which we allocate scarce resources. Talk about precision medicine and challenges with case studies. And given that I'm going to be there's a lot of slides and there's a lot of information and kind of concepts in my presentation, I'm just going to put this out there, and if you don't get anything else from my presentation, please get this, is that maximizing patients and public's utility, which some people use as the term value. I don't like to use value, so let's call it preference-based utility from an economic perspective, is actually a necessary condition for providing high value or efficient healthcare. And here's also the caveat here, is actually not a caveat, the corollary is that actually I think that patients and publics can make rational choices when confronted with these complex decisions associated with, for example, precision medicine, even in the face of uncertainty. I don't think it's easy to do that. I think that they need the right kinds of information by which they make their choices between alternatives. But I think that they can make difficult choices. And if they can indeed make those choices, then we need to value those choices through what I would say econometric and preference-based utility theory, and incorporate that into economic evaluation. So generally, what does Canada look like in terms of our reimbursement process? Well, it starts with Health Canada, who's a regulator that looks for safety. Our equivalent to NICE is called CADTH, which is the Canadian Agency for Drugs and Technology in Health. And we have 2 aspects of CADTH. One is a common drug review. This chord should actually be CODR, Pan-Canadian Oncology Review. So that means that's a separate process for oncology drugs. And then in Quebec, they have an S. And once they make recommendations about what is cost effective or not, or whether there is clinical benefit or not, it goes to a price negotiator. And then all the way at the bottom, and this is where it gets really difficult to understand the processes, because there's not a lot of transparency around these processes, is that each ministry and territory actually makes their own decisions. Making it a wee bit more complicated is that the fact that actually the cancer agencies in Canada, which are located in all the provinces, act as their own healthcare system. So they have separate processes outside the Ministry of Health. But generally, what can we say in health economics and the Canadian context, like the NICE context, is that we have this reference case. And for those who may not be familiar with health economics parlance, the reference case outlines a set of methods that are consistent with a specific objective. Okay? And so in the context of health economics, the objective is meant to be achieved through this thing called cost utility analysis, which is they want to maximize health status subject to a budget constraint, okay? In Canada, as in NICE, in England and Wales, they use this kind of thing called the ICER, which is incremental cost, so additional cost compared to effectiveness measured by the quality adjusted life year. And this quality adjusted life year is meant to incorporate both health-related quality of life and quantity of life. And so it's specified to be based on these generic instruments. At NICE, it's the EQ5D. In Canada, we're a bit more pragmatic. You can use the EQ5D, you can use the Health Utility Index, et cetera, et cetera. So the interesting thing about these is that actually we're not maximizing really health status. We're trying to maximize quality adjusted life years. That actually becomes very important in the context of precision medicine, because the question, as Mandy alluded to in the first session, is that does the quality adjusted life years fit for purpose? Does it encompass all the bits of value that patients and the public have when receiving care? Is it only about quality of life, or is there some process or non-health outcomes that are important? We'll get to that in a bit. So I'm going to have a definition, and these are working definitions for my presentation only. It does not apply to the world. This is just how I think about things. So I'm going to put this up here, precision health, which is kind of a new idea to me and was defined by Genome Canada, at least that's the first time I saw it, to encompass the idea of precision medicine to precision public health, where precision medicine is generally the idea that use multi-omics, so whole genome or whole exome sequencing, transcriptome sequencing, metabolomics, etc., to really try to tailor interventions to patients' physiologies. And by interventions, I'm actually going quite broad here. I'm not talking about drug therapies only. I'm actually talking about the return of prognostic information, which may or may not improve length of life or quality of life, diagnostic information, et cetera, et cetera. Okay, so these interventions, from my mind and my working definition, is quite broad. And we all know the narrative. We've heard the narrative this morning. We have the idea of probably more efficient healthcare, where efficiency, not in the economic way, efficiency is probably defined here as we can reduce costs through decreasing the deployment of futile therapies. So that's specifically talked about in the oncology space. Or we can decrease the costs through reducing the diagnostic odyssey, which is talked a lot about in the rare diseases space, for which there is varying levels of evidence to support both those claims. And the thing less talked about is precision medicine really tries to facilitate investment in discovery. Precision public health is an emerging omics field. I think it's emerging. I would say it is. For population disease screening, prevention, health promotion. I'm not going to talk too much about it, but in the area of oncology, circulating tumor DNA is a special promising area of the idea of precision health, in that you can use population screening for a relatively low-cost technology. And so here's the second disclaimer. I said there were two, this is second. So the second disclaimer is that actually precision medicine, precision health actually does not necessarily require new methods. It's not necessarily a special case study. I do think, however, that it amplifies challenges that we've already faced in resource allocation. So take the challenges that we usually have and then amplify them by quite a bit. And I think we have a fairly accurate depiction of what health economics or what precision is and what we're facing when evaluating these technologies. And here's a but. I hate buts, but here's a but. We're actually finding that parallel health technology assessment processes for precision medicine have been developed in British Columbia, which is where I'm from. It's ad hoc, really. Ontario has a formal, ongoing process where they're trying to say, hey, how do we evaluate precision medicine? And Quebec is developing one also. And I say that this is actually pretty important because we actually have processes in place already, but it's a signal to me that decision makers, and you'll see an example of this in a few slides, are kind of worried about it in terms of the potential non-marginal implications for costs of these multi-omic technologies and what those implications have for the healthcare system. So here's something that we conceptualized at the GSC and the Center for Clinical Genomics. This is not my slide. This is from Ali Carson. And so analytic validity, of course, clinical validity, clinical utility, which means is there effective treatment available for a specific variant or mutation. And then I came along, I guess, 5 years ago and said, hey, let's do some economic evaluation. And let's look also at the ethical and privacy issues. Now, these are not like groundbreaking things, but they are a kind of a process that we're trying to go through in terms of getting through oncology therapeutics and precision medicine through the BC system. And here's why it's kind of important. So what we're seeing, so this is an example of a private spin-off company out of the University of British Columbia. It's called Contextual Genomics. And I guess 2 years ago now, they were offering a panel, a next generation sequencing panel in the oncology space. And they were offering it for free for the first 1,500 patients, okay? And the whole idea was, hey, like we're here and all of Canada can access this, isn't this great? And here's the narrative that was kind of played out in the press coverage. So this, I think, was March 2016. So the chief medical officer, who I know very well, said the essence of personalized cancer care can be distilled into right treatment, right patient at the right time. So that's nothing new. It's just kind of angling again. And then he also goes on to say, 10 years ago, this would have been science fiction. But today it's actually cost effective to sequence someone's DNA and looking how we can personalize it, which is like, sounds really great. And you can see how this plays well in the media. The problem is that, and he made these claims 3 weeks ago at a Genome British Columbia event too. The problem is that, and we've done a literature review, the problem is that actually not a lot of these technologies for panels are cost effective in the oncology space. And so these claims are being made in the literature to the public and to patients without the supporting evidence, which I would argue contributes to uncertainty around benefit. And the CEO, who I also know and work with, says, hey, this mutation panel can achieve the scale needed to reduce costs. Okay, fair enough. Improve quality and increase availability regardless of which patient lives. So the overall narrative is actually pretty interesting. The overall narrative, again, is like, hey, reduce costs, efficiency, and actually we are improving equity. Here's the problem, of course, when they actually find a variant, the thing is that it may be off-label, as kind of was discussed earlier this morning. And so this is 3 months after they released this mutation panel. This individual got the free panel, and she's a mom, she's 33, she's single, and she had, I think, ovarian cancer, and they found a variant that was related to, so it's related to liver cancer, I think, Affinidor, and it cost $10,000 per patient per month of treatment, so very expensive. And so she's like, hey, there's an option, but there is an option, what's going on? And I think that the president of the BC Cancer Agency at the time summed it up quite nicely. It's like, hey, yeah, like we're a publicly funded system. It's very difficult to justify using very expensive treatment for which there is no evidence. So expensive, no evidence, I want it, what do we do? There's public pressure. So it's quite the societal conversation. I'll just go back to the bottom here of this slide. And so this is what's implemented in Canada. So BC Cancer, which is the institution I'm from. So like 6 months later, they actually implemented a panel that's an NGS panel that's available to everybody. So that public pressure really kind of sped things up in terms of we're going to adopt this. Now, she didn't get her treatment, but actually the panels are being implemented as standard of care at BC Cancer. It's the only place in Canada that has a panel that's standard of care. Of course, there's lots in the research setting. So Ontario, for example, has a very large panel. Of course, Oncotype DX and Prosigna are covered. Hereditary cancer testing actually does a little bit better in terms of implementing these panels. But I guess I say like this context in terms of not only what's implemented, but also to try to get us to understand actually the public and patients have a big role in determining what is covered or not. And the problem is that a lot of that information, and this is my first challenge, has uncertainty around it. Okay, evidence uncertainty. And so when you talk about uncertainty in precision medicine, we're talking about this multi-omics, and it provides a large amount of information, some of which can be interpreted. It has a multitude of implications for this individualized health, non-health outcomes, and process outcomes. Okay, and in terms of the uncertainty bit, the informational nature of precision medicine means that there are multiple and conditioned probabilities of outcomes. And I'll just quickly describe what this is. This means, for example, in the cancer space, I have to decide whether I'm going to get that needle core biopsy. I might actually be a lung cancer patient, and that has significant risks and benefits associated with that. So that's one decision. The next probability might look like, hey, there's a probability that a variant will be found, another probability, and also that that variant will have effective medical treatment associated with it. And so you get these streams of probabilities that patients kind of have to grapple with, okay? So that's one bit of uncertainty. The second bit of uncertainty is that because a lot of this information is generated from N-of-1 trials, from cohort studies without counterfactuals, there's actually a lot of significant precision or non-precision around outcomes, okay? And that's pretty important. And so let's just go back to like my first slide. I said, hey, we need to like understand utility. This is how it's done in the UK. So this is the EQ5D, 3L. And so a patient might mark, you know, this is my level. The problem is that none of this bit, none of these what's called domains incorporates the idea of like I have to wait to get the results of that whole genome test, which might delay treatment in some cases. In fact, this only incorporates under the skin bit, like what's my health-related quality of life. It doesn't incorporate the idea like, hey, we actually value the idea of information, which is sometimes called personal utility, outside of whether it changes my health care. So the EQ5D actually, in a lot of cases, especially in the context of uncertainty, in the context of information, the streams of information, may not be fit for purposes in all cases. And I'm a social scientist, I'm an economist, so I like to dig into literature a little bit. And so when I conceptualize uncertainty, and this came out of a paper I wrote with James Buchanan and Sarah and Dee too, we came up with, we did a lit review of how people conceptualize what's important in precision medicine for next generation sequencing. And I came across this idea is that in terms of uncertainty, so this is Frank Knight, who's an economist writing in 1921 using different language. But he said that risk applies to situations where we do not know the outcome, but can actually measure the odds. Okay, so this is the idea if we collect more information, we can we can look at a probability and maybe resolve some of the imprecision around estimates. Uncertainty, as he conceptualized it, on the other hand, applies to situations where we cannot know all the information we need in order to set accurate odds in the first place. And this is pretty important, I think. So this became like forgotten for many years. And then in the US housing crisis in 2008, it kind of like revived this old idea that actually in that context, they thought that they knew, and a lot of economic systems thought that they knew, how to mitigate risk across the system. The problem is they actually didn't understand the underlying risk because there's so many unknown factors. And so their misunderstanding and their kind of arrogance surrounding, I think I know the odds of this happening, almost like killed the global economy. And so this is actually interesting in terms of variants of unknown significance too, which is being returned in British Columbia in their hereditary cancer program, is that they're returning VUS, but we actually don't know if VUS, variants of unknown significance, actually are going to be demonstrated as causal of disease in the future. People want it because it maybe in the future will be, but we're valuing things, and this is the caveat in terms of what we value, is that actually some of these things may not be appropriate to value. And so I think we need to draw lines over what process health and non-health outcomes we're evaluating. So this is just to say we did this literature review. There's not a lot of out there in terms of patient and public preferences. This is actually my first, I think it's called a word cloud. I've never done them before, but I had a big table of what people valued, and it didn't really come across. So I did this word cloud thing. And of course, quality and quantity of life, so the quality of just life here is represented. But when the evidence suggests that when you ask people their preferences and you put that into an econometric model to say if they had utility, quantifiable utility for it, these are all the things that people value. In fact, they also value, for example, in the context of secondary findings or additional information, I'm dancing around too much, that they value treatments for which there's no effective treatment, information for which there's no effective treatment available. So they just value information in and of itself. Okay, and we can value that from an economics perspective, of course, but it's not captured in our reference case. It's not captured in the NICE reference case, as Mandy suggested earlier. And so I'll just quickly go over these challenges. So we found a few challenges in terms of how do we get the preference-based value for precision medicine and NGS. And of course, the easy challenge is that, hey, we have to value this range of health and non-health process outcomes. And this has been done by a few of us in the field. But actually, the thing called VUS, variants of unknown significance, in light of 19 uncertainty, I don't think should be valued. Okay? We also know that we have varying accuracy and prediction error, which James has looked at, and others, and they've looked at sensitivity, specificity, and accuracy, but preferences for uncertainty around outcomes has not been looked at. The simultaneous streams of cascading uncertainties, which is I discussed briefly, I think is pretty important, because actually if we don't incorporate that, we have something called endogeneity. And this is because when I have one choice, the outcomes of that choice will differ depending on whether I choose to receive information or not receive information. So the outcomes of information are endogenous to my subsequent choices. Okay, and if we don't incorporate that, we actually misvalue the preference-based utility for these things, and if we make decisions based on it, it's inaccurate. And I'm guilty about this too, is that, in fact, because this is so difficult, I just simplify the thing. And so we need to account for these ideas of endogeneity and indeed diminishing marginal utility as I have more and more information that becomes more and more complex. So I'm not going to talk too much about this. So I did recently in the United States, I did what's called a discrete choice experiment to get these values for precision medicine. And so we looked at stated preferences, utility for information on expected health and non-health outcomes. And I wanted to see whether it worked, whether there's some sort of external validity. So this is what the question looked like. Bizarrely, and they pushed me on this, was I needed to incorporate this thing down here, which is your average life gain, but there's uncertainty around that average. Okay, and so the question was, can people value this? Because like statisticians, at least my undergrads, don't do well with precision or confidence intervals. I framed it as a credible interval. I'm a Bayesian. But we wanted just to see whether people can actually value these sorts of things. And then we wanted to see whether it bore out the values in real life. So we looked at diffusion. Now, what diffusion of a technology is how the uptake of a technology over time in a healthcare system. So diffusion is like, okay, like how does that evolve over time? Because the general context is that there's varying uptakes of precision medicine technologies. And so we did Oncotype DX, or a 21 gene assay in the United States. And how we kind of got the change over time is we took our attribute levels of the discrete choice experiment. We say, well, how did the evidence change from 2005 to 2014 in terms of also out-of-pocket costs in the United States context? Probability of having a marker didn't change. Expert agreement did change. Of course, as guidelines become available, experts agreed that like Oncotype DX is a good thing or not. And then what we did is we actually looked at what was the real-world uptake of these technologies in the United States healthcare system. So we're able to do that through public filings, through data that's collected there. And here's what I found. So you have to remember, I did this discrete choice experiment, I put it in an econometric model, and then I calculated the probability of uptake. So a generic thing not related to breast cancer, and then I related it to breast cancer recurrence risk, okay? And this was a general population sample of 1,200 individuals who were patients recently. And so what did we find? Well, we actually found that my generic instrument, although blunt, in that it was like kind of like not super specific to Oncotype DX, did a fairly good job of, so this is the blue line, this purple line is actual, did a fairly good job of like calculating or getting it right at the beginning, really good job in the middle, and then we diverged at the end. And then I created this trend line that does even better. But the whole idea is that, so this question is hard, okay? And it's complex and has uncertainties in it. But people, when you provide them the right types of information to make informed choices, I do believe that they can make these complex choices, and I do believe we have external validity for it, okay? Now here's the other thing that we can do. We can measure willingness to pay. So what's your willingness to pay for information as evidence changes? And this is a measure of value which we can stick into a cost-benefit analysis. Okay, which is not the UK reference case, it's not the Canadian reference case, but it is something that we can look at. And so this is what I estimated through the discrete choice experiment. This is the real world price. So that's what Genomic Health actually charges for Oncotype DX. And what we see is that initially it was like way overpriced. So also this is the first probably DCE in the history of time that actually like did not exhibit what we call hypothetical bias, in that the willingness to pay estimates are below the actual estimates. And what we find is that actually it does track fairly well, but in the context of Genomic Health and their pricing schemes, there's probably a little bit of misalignment with their pricing scheme. Okay, there might be actually a decrease in consumer surplus if consumers indeed, and when they indeed have to pay for this information. So I'm almost done, I promise. So we're talking about a second challenge now. Just moving from, so that's the value side of things. How do we measure cost benefit or cost effectiveness? Okay? And generating the counterfactual is like the biggest thing I'm facing right now. And how do we get good methods for that? And so we know about 100,000 genomes, which is like, I think this is the right number. I mean, it's a moving target, I understand. But let's just say, for argument's sake, it's 300 million pounds, 400 million USD. All of us has turned into 1.4 billion in terms of how much money they're collecting for their 1 million genomes. The recently announced Australian initiative, of course, France. Of course, none of these large cohort studies that I'm aware of have counterfactuals, right? So we can have a whole bunch of information, and for information, we actually might be able to change care or provide a diagnosis, but we don't know how much better it is than standard care. That's a real problem, actually, because if we don't have that, we can't provide the evidence needed for adoption in our healthcare systems, okay? And so this is like a huge challenge. It's a huge challenge that we're guilty of in BC. And so my last kind of case study, and I was going to do some rare diseases context, but I'm just going to stick with oncology because it was quicker. So we have, at the Genome Sciences at BC Cancer, the Genome Sciences Center is like a world-leading institution. You know those circle diagrams that we saw in the 100,000 Genomes project? That was actually developed by the Genome Sciences Center, by a guy who's actually an artist and not a bioinformatician. Anyway, so that was developed there, and they're pretty good, let's say. And so they're doing something called whole genome and transcriptome analysis, and they're actually changing care for patients with incurable metastatic cancer, so very sick patients who don't have a lot of options. It's a phase 2 trial now, no RCT is planned. We are doing an umbrella trial for immunotherapies. We have 860 individual sequenced, so whole genome transcriptomes. And what we found in the first few phases, 22% of those people had actionable variants, 30% in phase 3. When I say actual finding, I mean actual finding and treatment available, because a lot of what we're finding through this whole genome transcriptome analysis in this population are things that are off-label. And so it's hard for us to, as we call it, get drug, okay? Because the public healthcare system won't pay for it, and nor should they. And so they have to, patients have to be put on available trials or go through something called the Compassionate Access Program. Here's the other thing you have to know about whole genome and transcriptome analysis. It is super expensive, okay? And so when they first started, it was like $60,000 per patient to do whole genomes and transcriptomes, okay? And that's not like an overestimate, that's actually what it cost. And that's what it costs a lot of people. And it's not necessarily just the technology. So we did see like a decline in price to around $20,000 as we changed platforms and as we increased throughput. But the problem is that bioinformatics, the cost of that is not changing. So we might change as throughput changes, but the thing to analyze it is actually super expensive, and that won't change. That won't change with AI or other big data methods. Machine learning, for example, is just because those methods aren't ready yet in this context, and we're saying no change in bioinformatics. And so the question is, okay, super expensive. We're doing a lot of discovery. It's pretty cool. But how are we doing in terms of improving people's lives? So we have to also remember 22% of people have informed care. That's not a lot of people, right? So 8 people don't have an actual variant. And so when we do our counterfactual matching based on our population level data sets, we do see this differentiating line. So this is people who actual finding with drug. And so they have better survival based on this Kaplan-Meier. Here's our counterfactual reference group. And here is our whole genome transcriptome analysis, non-informed treatment, so the people who didn't have an actionable finding. And so we see this differentiated curve. I don't have the slide, and I should, but I'm hesitant to present it, is that when we combine that green and red line, we actually find, in the Kaplan-Meier analysis anyway, that we're not changing people's length of life. We're doing a whole bunch of discovery, which is great, and it's brilliant, it has worldwide implications, but at least, and we have to also understand this is for a small time frame, okay, so that's the other context, caveats. But we're actually not changing a lot. If we do parametric analysis, we can kind of maybe see a 2-month gain in life, but of course that has assumptions in terms of projecting life expectancy into the future based on a whole bunch of statistical assumptions that probably don't hold up. So, I think this is my final slide. So here's a few summary issues. I just want to make it simple, is that, okay, so the clinical implementation of next-gen sequencing technologies is quite varied and indeed like really limited in Canada. And it's really mostly in the research space, which is probably appropriate. There is sparse evidence of cost effectiveness. There are a few exceptions. Oncotype DX actually tends to be cost effective. EGFR testing, KRAS testing, EGFR in non-small cell lung cancer, EGFR in colorectal cancer, fairly cost effective, although still pretty costly for what you get. And we're doing all these large cohorts, these very large cohorts, but we're actually we're not getting any randomized control trial evidence, which is like needed as a step. It's not the only step that's needed. So don't get me wrong, I'm not like a super big fan of RCTs, but I think it is like a hoop that we need to jump through. And then look at real world evidence surrounding cost effectiveness. And so we actually need to start thinking through how to identify appropriate counterfactuals through what's called quasi-experimental methodologies. And here's the other big bit, is that I think precision medicine for patients is a lot about information that can have an impact on quality and quantity of life, but also has an impact of health, process outcomes, and these need to be valued and incorporated into analyses. And I think the challenge here is that we need to less preference-based utility so we can do the economic evaluation, but we actually have to do better at accurately depicting the risks and the benefits associated from these streams of probabilities of biopsies, of having a variant or not, the implications to families, et cetera, et cetera. And we don't do that well now. But the great thing is, like, for us in health economics, there's like a lot of research that we can do. So it's an interesting area to be in right now. So I think I'm gonna leave it at that. So my team is like these people right here, and then my collaborators are these people, and actually they're the people who do most of the work. I just get to go to Oxford and talk. Thank you.